This is a summary of the trial led by Associate Professor Narelle Cox, examining the effect of telerehabilitation for people with chronic respiratory disease, which was published in Thorax in 2022. This trial was awarded by PEDro as one of the top 5 trials published between 2020 and 2024. Pulmonary rehabilitation is an effective treatment for people with chronic respiratory disease. However, it is delivered to less than 5% of eligible individuals. This study investigated whether home-based telerehabilitation was equivalent to centre-based pulmonary rehabilitation in people with chronic respiratory disease. A multi-centre randomised control trial with assessor blinding, powered for equivalence, was undertaken. Individuals with a chronic respiratory disease referred to pulmonary rehabilitation were eligible, and they attended an initial in-person assessment at a hospital and were then randomised using concealed allocation to pulmonary rehabilitation or telerehabilitation. Both programs trained twice per week for 8 weeks in a group setting, with the exercise component consisting of supervised aerobic and strength training. The primary outcome was the change in the chronic respiratory disease questionnaire dyspnea domain at the end of rehabilitation, with a pre-specified equivalence margin of 2.5 points. Follow-up was at 12 months. A secondary outcome included exercise capacity measured by the 6-minute walk test. 142 participants were randomised to pulmonary rehabilitation or telerehabilitation. There were no significant differences between groups for any outcome at either the end of rehabilitation or at 12 months follow-up. Both groups achieved meaningful improvement in dyspnea and exercise capacity at the end of rehabilitation. Equivalence of telerehabilitation for the primary outcome of change in dyspnea at the end of rehabilitation could not be confirmed, with a mean difference of -1 point, with the 95% confidence interval of -3 to -1 point. And inferiority of telerehabilitation could not be excluded at either the end of rehabilitation or at the 12-month follow-up time point. At the end of rehabilitation, telerehabilitation demonstrated equivalence for the 6-minute walk distance, with a mean difference of -6 metres, with a 95% confidence interval of -26 metres to 15 metres, and with possibly superiority of telerehabilitation at 12 months. Whilst telerehabilitation may not be equivalent to centre-based pulmonary rehabilitation for all outcomes, it is safe and achieves clinically meaningful benefits. When centre-based pulmonary rehabilitation is not available, telerehabilitation may provide an alternative program model.